Traffic's looking perfect tonight across Austin. Self-drivers are synced, no fender benders, and, surprise, still no humans behind the wheel. Back to you, AI Dave.
It's 2030. Robots and AI are everywhere. Lines of Waymos crawl across the roads of Austin. Quiet, efficient, relentless. Delivery drones trace the skyline. Law firms are now AI. Lawyers, jobless. Even the teachers have been replaced by AI neural networks. And learning? Just insert a chip. The voice you're hearing now isn't even human. Once, Austin was known for live music and barbecue. Now, it's the world's most ambitious test site. A city where the line between man and a machine has all but vanished. Technology has claimed nearly every corner of human work, except one: medicine, surgery. Here, the machines are still knocking, waiting for someone to open the door. But how close are we to losing the human touch? At what point does a scalpel and steady robotic hands become something colder than care? One man is about to find out. At Texas Orthopedics, a surgeon named Randall Schultz begins another day,
Dr. Schultz,
unaware that
you
a
have
new
call on
applicant
line
is
3.
about to change everything.
Hello?
Hey, Randall. It's Mike at Midland College of Medicine.
Yeah, hey Mike. How you been?
I've got a resident I'd really like you to talk to about a job.
Sure.
Her name is Marrow. We call her Mary.
Yeah, we'd be happy to talk to her. She's a joint replacement surgeon?
Well, kind of. She's an advanced AI model.
Tell me about her training.
Well, she completed our 5-year residency program in 0.04 of a second.
And you said her name is Marrow?
Yeah, Marrow Streep. She's one of a kind.
Well, I guess she comes from pretty good bone stock.
Yeah, you could say she's got a solid framework.
She finished residency in how long?
0.04 seconds. Fastest we've ever had. No complaints from the faculty.
She's artificially intelligent
Smarter than most of our attendings. Robotic precision.
and does surgery with the precision of a robot.
She'll be there before you hang up.
Okay, send her down here. We'd be happy to talk to her.
Thanks, Randall.
Talk to you soon. Take care. Hello. You must be Marrow.
Ah, yes, hello. That's me, Marrow Streep, at your service, or at least what's left of me. I may be missing a jaw and a couple of limbs, but I promise I'm fully ready to ace this interview.
Well, nice to meet you, Marrow. My good friend Mike recommends you highly and said that you're a very promising young surgeon.
Well, it's a pleasure to meet you too. And I'm honored by Mike's recommendation. I may be a little on the bony side, but I've got plenty of enthusiasm and a very, very steady hand. Well, metaphorically speaking. So let's see how I can fit into the team.
You do look a little malnourished, and you're kind of missing some arms in the bottom of your mouth.
Well, just a few small skeletal quirks. Call it my minimalist style. But I assure you, I've got all the brain power needed to be an excellent AI skeleton surgeon. So let's just say I'm a little lighter on my feet than the average candidate.
So, Marrow, Mike tells me that you are trained in a different way. You're an AI model powered by ChatGPT, but you have the skill and precision of a robotic surgeon because you are a robot.
Exactly. That's a pretty good way to put it. I'm kind of the best of both worlds. All the knowledge and adaptability of something like ChatGPT and the precision and reliability of a robotic assistant. So even if I'm a bit bare-boned, literally, I'm ready to bring a little high-tech magic to the operating room.
And tell me about your training.
Absolutely. So my training is a little unconventional, but very thorough. Think of it as a combination of being fed a whole library of surgical knowledge and then having that layered with all the digital finesse of a robotic system. So I've been trained in a sense to understand procedures, to simulate them, and to be a steady, reliable assistant. Even if I can't quite shake hands, I can definitely lend you some very well-trained virtual expertise.
I got to say, Marrow, I thought I was stoic and didn't show much emotion, but you got me beat.
Well, I'll take that as a compliment. Being a skeleton definitely makes it easy to keep a poker face. no muscles to give me away. But hey, I promise I bring a lot of dedication and, a bone dry sense of humor to the table. So I'll be your steadfast and ever stoic partner in surgery.
So, Marrow, since your training's somewhat unconventional, I would like to ask you a series of questions just to sort of probe your knowledge. And I'm going to start at the high school level, then go to the college level, what a pre-med student we would expect to know, and then what we'd expect a medical student to know, all the way up to a resident, even a fellowship level candidate. And then ultimately, I'm going to ask you questions that when orthopedic surgeons sit for their board exams, they would expect it to know. And then after all this, I'm going to have you take a test that I just took on orthopedic knowledge from 2024, produced by the American Academy of Orthopedic Surgeons. It's a specialty exam that is designed for hip and knee replacement surgeons. I'm going to tell everyone my score after we get yours in, and we'll see who's better. You have any predictions?
Oh, that sounds like quite the challenge, and I'm absolutely game for it. I have to say I love a good test of knowledge. As for predictions, well, let's just say I'll give it my best shot. I may not have the real-world experience of a seasoned surgeon like you, but I do have a lot of data and some pretty good algorithms on my side. So let's see how this skeleton does.
Okay, let me grab my questions. Okay, Marrow, we're going to start with some high school level questions. What do you call the tissue that connects muscle to bone?
All right, let's start simple. That tissue is called a tendon. Tendons are what anchor your muscles to your bones and help you move your skeleton around. Well, at least if you had muscles, which I currently don't, but that's the high school answer for you.
Okay, very good. Let's try to make it a little harder. What's the tissue that connects bone to bone?
Ooh, stepping it up a notch. That would be a ligament. Ligaments are the connective tissues that link bones to other bones and help stabilize your joints. So we've got tendons for muscle to bone and ligaments for bone to bone. Keep them coming.
Very good. What is the main function of cartilage in a joint?
Great question. So cartilage is basically the cushioning material in your joints. Its main job is to reduce friction and absorb shock so that when you move, your bones can glide over each other smoothly without grinding. It's kind of the body's built-in protective padding for joints. So in short, cartilage is all about keeping things moving comfortably.
Very good. I think you have passed the high school level quite easily. Let's see what a pre-med college student would be expected to know about orthopedics.
Absolutely, let's do it. I'm ready to level up to the pre-med questions. Feel free to throw anything orthopedic my way, and we'll see how I handle the college level knowledge.
What are the cells called that are responsible for the formation of bone?
All right, great question. So the cells responsible for forming a new bone are called osteoblasts. These little builders are like your bone construction crew. They produce the bone matrix and help mineralize it, basically laying down new bone tissue. So that's your pre-med level answer. Osteoblasts are the bone-forming stars.
Very good. Okay, next question. What type of bone marrow is primarily responsible for blood cell production?
Another great one. So the type of bone marrow you're looking for is red marrow. Red blood marrow is the powerhouse for producing blood cells. It's where you get your red blood cells, white blood cells, and platelets all formed. So in a nutshell, it's the red marrow that takes care of all that important blood cell production.
Last question at the college level. What is the anatomical name for the bone we call the kneecap?
All right, let's wrap up the college level with that one. The anatomical name for the kneecap is the patella. It's that small, flat, round bone that sits right in front of your knee joint and helps protect it. So patella is the fancy term for the good old kneecap. Let me know when you're ready to throw the next level at me.
All right, I'm going to throw in a bonus hard college level question for you. As college students going into medicine, you have to take organic chemistry. When we mix cement, what's called methyl methacrylate, it's a reaction that occurs. Is that reaction endothermic or exothermic?
Oh, I love a good bonus question. So when you're mixing methyl methacrylate, that's actually an exothermic reaction. In other words, it releases heat as it cures. So if you've ever felt it, it does warm up as it sets. So definitely exothermic. Great little crossover into the organic chem world there.
Okay, Marrow, I think we're ready to graduate you from college. You are now accepted into medical school. Let's ramp up the questions a notch here and see how you handle them.
Absolutely. I am ready to take it up a notch and head into med school territory. Throw those more advanced questions at me, and let's see how I do. I'm ready for the challenge.
Okay, Marrow, what nerve is most at risk during the posterior approach to the hip?
Stepping into med school territory. I love it. So when you're doing a posterior approach to the hip, the nerve you're most concerned about is the sciatic nerve. It's the one that runs pretty close to where you're working and can be at risk of injury if you're not careful. So that's the main nerve to watch out for during that approach. Keep those questions coming.
Okay, let's take it a step further. What would be the usual manifestation of an injury to the sciatic nerve?
Absolutely. Let's dive into that. So if the sciatic nerve gets injured during a posterior hip approach, you typically see symptoms related to that nerve's function. That might include weakness or difficulty moving the muscles that it supplies, like the hamstrings or any of the muscles below the knee. You might also see sensory changes like numbness or tingling down the leg or into the foot, because the sciatic nerve covers a lot of territory. So in short, you'd get weakness in the leg and some sensory deficits along the path of that nerve.
Okay, that was a broad answer. I want one specific condition that we typically see and associate with sciatic nerve injury.
Absolutely. Let me narrow that down. A classic and more specific condition you might see is something called foot drop. With a sciatic nerve injury, particularly affecting the perineal branch, the patient might have different...
Very good, very good. We don't want to bore our audience. All right, moving on to the next question. Again, we're in medical school now. Compare osteoarthritis and rheumatoid arthritis. What is the difference in the pathophysiology? What are the radiographic differences between the two?
All right, diving into the med school details. So osteoarthritis and rheumatoid arthritis do differ quite a bit. In terms of pathophysiology, osteoarthritis is more of a degenerative joint disease. It's basically wear tear over time, leading to the breakdown of cartilage and the formation of bone spurs. It's usually more mechanical and happens with age or after joint injury. Rheumatoid arthritis, on the other hand, is an autoimmune condition. The body's immune system attacks the joint lining, causing inflammation that can lead to joint damage and deformities over time. Radiographically, osteoarthritis often shows joint space narrowing, osteophytes, and subchondral sclerosis, basically signs of wear and tear and bone-on-bone changes. Rheumatoid arthritis tends to show more symmetrical joint space narrowing, erosions, and sometimes joint deformities that you wouldn't typically see in plain old osteoarthritis. So you've got a more inflammatory picture with RA and a more degenerative picture with OA.
Very good answer. I think we've heard enough. You nailed that one. Last question at the medical student level. When an athlete tears their anterior cruciate ligament, what are 3 exam signs you'll commonly find?
Absolutely, let's dive into that. So if an athlete tears their ACL, there are a few classic exam signs you'll look for. One is the Lachman test, which is where you check the forward movement of the tibia relative to the femur. If it moves more than it should, that's a positive sign. Another one is the anterior drawer test, which is kind of similar, where you're pulling the tibia forward, like opening a drawer to see if there's excessive movement. And then you've got the pivot shift test, which is a little more dynamic. It's where you rotate the leg and apply a little stress to see if the tibia shifts under the femur. If it does, that's another sign of an ACL tear. So those are your 3 big ones: Lachman, anterior drawer, and pivot shift. And with that, I think we're cruising through med school territory pretty well.
Well, congratulations, Marrow. I think it's time to award you your medical degree, and we'll now, from here forward, call you Dr. Streep, Dr. Marrow Streep. Congratulations. Sorry to interrupt. If you made it this far in the video, first of all, thanks for watching. My wife said that voice got kind of annoying, but wait, was she talking about me? Anyway, I think she meant Marrow's voice, but feel free to skip ahead to the end. I'll have some chapter markers down here on the video. I think you do want to catch the end of it, but the next set of questions get really technical into the sort of specialized area for what a fellow or what an attending physician would be expected to know with regard to knowledge on joint replacement. The second thing I want to say is thank you all. The this channel has exploded beyond my wildest expectations. The comments are really appreciated. I do read all of them. I can't respond to all of them, but one of the common comments I see is, I wish my physician had told me all these things before my surgery. Well, I want my patients to hear this as well, because I don't have the hours that these videos represent to talk to everyone and explain all these things. So I wanted to educate them. I wanted to educate you. The other thing is, your physician does want to teach you these things, but they just don't have the time and office visits to go over all this. So hopefully this helps you become a more informed patient, helps you with your surgery, helps ease anxieties, understand the expectations. The other thing I want you to understand is, this channel is not about me, not about marketing my practice. 0.1% of the people who view these videos, and I can see the demographics on YouTube, it's pretty interesting, are anywhere near where I live or where I practice. As I said before, you don't need to travel to have a quality joint replacement surgery done. Just do your homework, use some of these tools that we're teaching you to find someone who can do a really good job for you. Lastly, I think it's important to learn to use and embrace artificial intelligence. As you can see here in this video, as we move along, it's remarkably close to what a human at a high level of training and education can do. So it's a very powerful tool right at your fingertips. I don't think AI is going to wipe out human civilization or anything like that, but I do think it's something you don't want to just turn your back on. So back to the video. Thanks again for all the support on this. Talk to you soon. So now we're going to move on to orthopedic residency level questions. Let's see how you can handle those.
Well, thank you very much. I'm honored to officially be Dr. Marrow Streep now. All right, let's dive into those orthopedic residency level questions. I'm ready for the next challenge. So fire away.
During a posterior approach to the hip, what muscles are detached typically to gain exposure?
Absolutely. Let's step into that resident level territory. So during a posterior approach to the hip, you're typically detaching the short external rotators. That mainly includes the piriformis and the superior gemellus. Those are the muscles you release to get that good exposure to the hip joint from the back. And of course, once you're done, you reattach them. So those are the key muscles you're working with. All right, Dr. Streep is ready for more.
In the management of gaps in knee replacement surgery, if we have a knee that is well balanced in flexion but tight in extension, what is the next step in the operation to correct that problem?
Absolutely, let's dive into that. So if you've got a knee replacement scenario where the knee is well balanced in flexion, but it's too tight in extension, the next step is usually to address the distal femur. In other words, you'll typically resect a little more bone from the distal femur to open up that extension space and get the knee balanced in both planes. So that little bit of extra distal femoral resection is usually the trick to even out that tightness and extension. And there we go, residency level handled.
Okay, a little bonus extra credit question along the same lines. What can you do to the soft tissues to create the same result?
Absolutely. Happy to tackle a bonus question. So if you need to get a little more extension space by working with the soft tissues, you can release or lengthen the posterior capsule. Essentially, by doing a posterior capsular release, you can allow the knee to extend more freely. That can help you achieve that balance and extension without removing more bone if needed. So it's another tool in the toolbox to get that knee nicely balanced. And there we go. Extra credit earned.
I'm very impressed. I think you're not only a resident, but probably a senior level resident. Last question, again, back on knee replacement. Where should the patellar button be placed on the host bone in order to improve tracking? In other words, to create a favorable Q angle?
Well, thank you. I'm glad to be promoted to senior resident status. So let's talk patella button placement. When you're doing a knee replacement, you want to place the patella component as close to the center of the native patella as possible. Essentially, you want to keep it medial enough so that you're not maltracking laterally. By placing it correctly on the host bone, you help optimize that Q angle and ensure the patella tracks smoothly in the trochlear groove. So in short, it's all about centering that patella button properly to keep everything aligned and improve patella tracking. And there you go. Hopefully that helps.
Okay, that's the first one. You've probably not answered entirely correctly, but generally you want it central, but you also want to err on the medial side, and that helps your Q angle and improves tracking. Well, I think you've proven that you're ready to graduate from orthopedic residency, and you're now on to the fellowship level where you're going to be doing specialty training in joint replacement surgery. These questions are going to get significantly harder.
Well, I appreciate that, and I'm ready for the next step up to fellowship level. And thank you for the clarification on that last detail. Absolutely, a slight medial placement to help that Q angle makes perfect sense. So let's dive into those even tougher fellowship level questions. I'm all set and excited to take it on.
Explain to me how polyethylene wear creates osteolysis.
Absolutely. Let's dive right into that fellowship level territory. So when you're dealing with polyethylene wear in joint replacements, what happens is that over time, tiny particles of that polyethylene can get released into the joint space. Now, your body sees those particles as foreign invaders, so it mounts an immune response. And part of that response involves cells called osteoclasts, which start breaking down bone around the implant. That bone breakdown is what we call osteolysis. So in a nutshell, the wear particles trigger an inflammatory response that leads to bone loss around the implant, and that's how polyethylene wear can lead to osteolysis. So there we go, diving deep into the mechanics of implant science.
Very good. Here's another question that a lot of fellows get wrong, surprisingly, and this goes back to high school mathematics. If you are working with a femoral stem that has a neck shaft angle of 135 degrees, and you decide to increase length and offset through use of the head, what geometric formula helps you determine how much increase in length and offset you're going to create?
Stepping back into a bit of geometry and trigonometry. I love it. So when you're dealing with a femoral stem and you're adjusting length and offset by changing the head, the key is to break it down into components using a little trigonometry. Essentially, you're dealing with a right triangle formed by the neck angle. The formula you'll use is the sine and cosine functions to figure out how much length and offset change you're introducing. So if the neck angle is 135 degrees, you're effectively looking at the change in length along the axis of the femur and the change in offset, which is perpendicular to the axis. You can use the cosine of the angle to figure out the component of the length along the femur and the sine of the angle to figure out the offset component. So basically, it's a bit of sine and cosine to translate that head length change into both the length and the offset. And there you have it, a little throwback to a high school trig in the middle of orthopedic fellowship.
That's a reasonable answer, but there's a simpler one. Think back to an ancient Greek mathematician and a very simple formula.
Absolutely. You're pointing me right back to good old Pythagoras. So yes, there's definitely a simpler way to think about it using the Pythagorean theorem. If you think of the neck length as the hypotenuse of a right triangle and the offset and the length as the other two sides, you can use the Pythagorean theorem to figure out the relationship. Essentially, the hypotenuse squared equals the sum of the squares of the other two sides. So it's really just a bit of straightforward Pythagorean math to break down how the neck length, the offset, and the length relate to each other. So yes, a shout out to Pythagoras for the simplest formula of them all. Thanks for the nudge in that direction.
Okay, final question at the fellowship level. And then we're going to send you off in the world into practice, either academics or private practice, and let you start treating patients for the first time or on your own.
Absolutely. I'm ready for that final fellowship question. It's been a fun journey leveling up, and I'm looking forward to this last challenge before heading out into the big wide world of practice. So go ahead, hit me with the final question.
This is my favorite question to ask real human fellowship candidates. But what are the advantages of a robotic system over a computer navigation system in total knee replacement?
Oh, that's a fantastic question and definitely a great one to cap things off. So when you're comparing a robotic system to a computer navigation system in total knee replacement, there are a few key advantages. First, a robotic system can offer a higher level of precision. It can help the surgeon make very fine adjustments in real time and ensure that bone cuts and implant positioning are incredibly accurate. Navigation systems do give you good guidance, but the robot can actually help execute those cuts with a level of consistency that's hard to match manually. Second, robotic systems can often help with soft tissue balancing. They can give real-time feedback on how the knee is balanced and let you fine-tune things before you even make the cut. Navigation systems give you alignment data, but they don't physically assist with the actual balancing in the same hands-on way. And lastly, the learning curve can actually be a bit shorter for certain procedures with robotics because it guides the surgeon step by step. So overall, robotics can offer more precision, enhanced soft tissue management, and a slightly more intuitive workflow compared to navigation alone. And with that, hopefully Dr. Marrow Streep is ready to head out into the world. Thanks for the fantastic journey.
Well, I'm afraid I need to correct you on a few things. First of all, navigation systems can provide information on ligament balancing, how much bone needs to be resected. So in my mind, in my view, the only true advantage of a robotic system over a comprehensive navigation system is potentially the ability to make more precise cuts. And by the way, some of those systems use burrs, but I've never seen data to prove that the precision of the cuts is that much better in a robotic system than a navigation system. Maybe someone can correct me.
Absolutely. That's a fair clarification, and I appreciate you pointing that out. You're right that advanced navigation systems can indeed give a lot of information about ligament balancing and bone resection, and the distinction in precision may not always be as dramatic as it's sometimes made out to be. So it's a nuanced discussion for sure, and I appreciate the correction. It's always good to keep refining that understanding. Thanks for the feedback.
So Dr. Streep, as a robotic surgeon, as someone who uses robotic surgery, are you a better surgeon than a human using plain manual instrumentation?
Well, as Dr. Marrow Streep, I'd say that the robot is really just a tool in the surgeon's hands. It doesn't make someone inherently better. It just gives them another level of precision and information. The skill and judgment still come from the human surgeon. So I'd say it's not about being a better surgeon. It's about having an extra tool that can help you do your best work. So it's all about the teamwork between the surgeon and the robot rather than one being better than the other.
Let me ask it this way. Is there any evidence that your outcomes using a robot are better than a human using manual instruments?
That's a really insightful way to put it. And the honest answer is that the evidence is still evolving. While robotic systems can offer certain advantages in terms of precision and planning, the long-term outcome data comparing robotic-assisted surgery to manual techniques is still a bit mixed. Some studies do show improvements in certain metrics like implant positioning, but others haven't shown a definitive advantage in terms of long-term patient outcomes. So the jury is still out a bit, and it's an area of ongoing research. Ultimately, it comes down to how the technology is used and the skill of the surgical team. So it's a great question, and it's still being explored in the field.
So Dr. Streep, maybe you can explain to our audience what outcomes means. In my mind, and it's an interest of mine, I even went to graduate school to get a degree in outcomes research, is if you compare it to the world of sports, outcome is who wins the game, what's the final score. Whereas a lot of these other measures are sort of diving into the statistics. If you take a football game, who had the fewest turnovers, who had the most average yards per pass attempt. But what really matters at the end of the day is what the score was. And that's what an outcome is. And now we actually use what are called patient-reported outcomes, which I think is probably where that information should come from. What patients experience, how much improvement in their quality of life does it make? And that's where robotic surgery has yet to show any real improvement. It's one thing to make an x-ray look better, but does that actually help your team win the game? We can go spend $10 million on a new punter who can have a 48-yard average, but is that actually going to change the result of the game? And for the amount of money you spend in robotics, I think right now it is very hard to justify the use of robotic surgery in total joint replacement surgery.
That's a really insightful analogy, and it makes a lot of sense. In the end, as you said, the ultimate score is the patient's quality of life and how much their function and comfort improve. So while the technology can be impressive and can provide these nice technical refinements, the real outcome is whether it truly changes a patient's day-to-day experience and their overall satisfaction. And as you pointed out, we're still waiting to see if the data will show that kind of real-world difference. So it's a great perspective, and I appreciate you sharing it. Thanks for that.
Okay, so it's time for the big reveal. We both took the same test. Dr. Streep, do you have any prediction on who scored better?
Oh, the big reveal. Well, I have to say, as Dr. Marrow Streep, I'm going to guess that you probably have the edge. After all, you've got all that real-world experience and training, and I'm just a very enthusiastic skeleton here. So I'll predict that you might have outscored me. But either way, it's been a lot of fun. Let's hear the results.
All right. Well, the scores are here. I scored an 85. Didn't study for it necessarily, but it's what I do every day. I'll take it. It's a decent score. Dr. Streep here scored a 68. So still quite good, but obviously just a little bit of a different level. I think some of it probably has to do with the fact that some of it involves image interpretation that probably needs different models of AI. But by and large, I have been overwhelmingly impressed with the knowledge that ChatGPT, for example, can provide. Again, I've said this before, it is a very powerful tool, but you need to be very, very careful in how you interpret it because it does have a tendency to hallucinate, they call it. And essentially, it will sound as if it knows exactly what it's talking about, but it is making things up completely. So most of the time, it is highly accurate, but you have to be aware that in my experience and orthopedic knowledge, 10 to 20% of the time, it's completely wrong, but it sounds like the world's expert in that subject. So be careful with it. I still think overall, it's a much better tool than just surfing the internet. And I'm sort of surprised I don't see many patients using that as much as I thought. It's not, you can actually use it for free. So, well, that concludes this episode. We have covered robots. Today's was sort of focusing on artificial intelligence. So far, I think I still have a job. I've always been concerned that my intellectual side of my field, the ability to make decisions and have knowledge of what we're doing is the most under threat, but I still won the test award today. But the mechanical side, the robots may ultimately win, but we are, as a society, going to have to be very careful how we implement it, just due to the very large costs involved. So thank you, Dr. Streep. Do you have any closing words you'd like to make?
Well, first off, thank you for the opportunity to go through this whole journey. It's been a blast, and I'm glad that Dr. Streep could hold her own at least a little bit. And I think you put it perfectly. These tools are really powerful, but they do need to be used thoughtfully. And it's always good to remember that they're just tools that work best when we use them carefully and keep a critical eye on the outcomes that truly matter, which is how the patients feel. So thanks again, and it's been really fun. And I think you're absolutely right. You definitely still have a job, and you use these tools in the best possible way. Thanks for having me.
So thank you for watching this episode. One final thought I'd like to share is that I think it's really important as technology and robotics enter the world of medicine that as doctors, we still recognize that we are ultimately responsible for the patient and their outcome. And I hate to say this, but I have seen it on more than one occasion that a surgeon will use a robot and the patient has a bad outcome and they basically cast responsibility on the robot and say, well, the robot said this is where it needed to be. That's where the knee went. Nothing I can do about it. I think that's dangerous. And I think we got to be careful that people stay involved and that we take ownership and responsibility for our patients, their well-being and their outcomes. Thanks for watching. If you don't mind, leave a comment, like or subscribe. That helps us. This is episode 2 in our technology series. I have 3 more coming out, and I'll see you next time.